All right. Hello, I'm Duncan and I'm a pharmacist. I'm here to discuss patient Matthew Martin in the ICU. His birth date is 8/18/1954. I was just asked to provide a recommendation on whether or not to use corticosteroids for this patient. He's a 70-year-old male who was brought into the ED for fever, chills, chest pain, and productive cough, dyspnea, fatigue, and weakness. His symptoms started 4 days ago and have progressively gotten worse. His O2 sats upon admission to the ED were 82% on room air, so he was started on 6 liters of oxygen via nasal cannula, and then that was bumped up to an O2 sat of 84 once he was started. He's currently being treated or transitioned to high flow oxygen therapy with an FiO2 of 50% and at a rate of 20 liters per minute, and his PaO2 FiO2 ratio is less than 300. Mr. Martin's PSI, which was calculated in the ED, was greater than 130, and Dr. Stevens has classified him as having severe community-acquired pneumonia requiring admission to the ICU with high flow oxygen. And he's hoping to avoid mechanical ventilation. Chest x-ray showed right, middle, and lower lobe infiltrates. The respiratory rapid panel showed no COVID or influenza or any other viruses. The sputum gram stain showed gram-positive Diplococcus. And then some pertinent labs were a white blood cell count of 20, with neutrophils 72% and bands of 11%. And then his serum creatinine was 1.2, vitals, blood pressure of 138/76, respiratory rate of 30, temperature 38.7, and a heart rate of 88. His past medical history, he has hypertension, hyperlipidemia, and hypothyroidism, as well as a social history of tobacco use, 1 pack per day for 40 years, and then some alcohol use, just a couple drinks a week. Home medications, the telmisartan 40 milligrams daily, rosuvastatin 10 milligrams daily, levothyroxine 75 micrograms daily, and a multivitamin daily. And then once he was admitted in the ED, they started ceftriaxone 2 grams IV every 24 hours, and azithromycin 500 milligrams IV every 24 hours, as well as heparin 40 milligrams subcutaneous daily, and a saline drip at 100 mils per hour, and then the famotidine IV twice daily. So there was a study titled Hydrocortisone in Severe Community-Acquired Pneumonia that discussed the outcomes of hydrocortisone use for severe community-acquired pneumonia. The study looked at adult patients with severe pneumonia admitted to the ICU. All the patients in the trial received standard therapy, including antibiotics and supportive care. The trial defined severe pneumonia as having one of the following criteria. So it was either initiation of a mechanical ventilation, initiation of oxygen through a high flow nasal cannula with a ratio of the partial pressure of arterial oxygen to inspired fraction of oxygen of less than 300 with a FiO2 of 50% or more. And then, or if the patient was wearing a non-breathing mask and had an estimated PaO2 FiO2 ratio of less than 300, or a score on the pulmonary severity index more than 130. There was a lot of exclusion criteria in the trial. Well, the biggest ones that I noted were if the patient had septic shock, if the patient had suspected inhalation pneumonia, if they didn't meet the inclusion criteria, they were diagnosed with influenza or had received corticosteroids for other medical conditions, or if they had received antibiotic therapy for more than 7 days. And then there was some other exclusion criteria, but the patient didn't have any of those either. The intervention evaluated in the trial was IV hydrocortisone 200 milligrams daily for either 4 days or 7 days, followed by a taper of 8 or 14 days. The comparator was placebo, and the primary outcome of the study was mortality at 28 days. There were some secondary outcomes, namely mortality at 90 days, incidence of mechanical ventilation by day 28, incidence of endotracheal intubation by 28 days, and incidence of vasopressors by day 28. They also looked at safety outcomes like incidence of ventilator-associated pneumonia by day 28, incidence of bloodstream infection by day 28, incidence of GAI bleed by day 28. Oh, sorry. Or a median daily dose of insulin by day 7, or a median weight change from the baseline at day 7. The study took place in 31 French centers by the Clinical Research in Intensive Care and Sepsis Trial Group for Global Evaluation and Research in Sepsis. The study was a multi-center, double-blind, randomized superiority controlled trial. The primary outcome was a decrease of 5.6% in mortality in the hydrocortisone group. All of the secondary outcomes favored the hydrocortisone group, and then the safety outcomes were either weren't statistically significant, or in the case of the insulin, it favored the placebo group, and the weight gain also slightly favored the placebo group. Based on the inclusion and exclusion criteria, Mr. Martin would fit as a participant of this study, so I guess he fits within the confines of the study. He is an adult who is admitted to the ICU with severe community-acquired pneumonia. He fits the severity of the trial because he was on the high-flow nasal cannula, and his PaO2, FiO2 ratio is less than 300, and his FiO2 is at least 50%. He did not meet any of the exclusion criteria listed in the trial, and then the patient is also currently on antibiotics and supportive care for the treatment of pneumonia, which also fits within the confines of the study. One weakness that the study had was that it technically wasn't sufficiently powered. However, since there was still a statistically significant difference in the mortality and the secondary outcomes, we can sort of count those results as relevant. Just they could have been better results if it had been more participants in the study. The study was also funded by the French Ministry of Health, which shows little evidence of bias, and it was also published in the New England Journal of Medicine, which is refutable. And then the study design is a good study design. The ATS-IDSA guideline for diagnosis and treatment of adults with community-acquired pneumonia recommend against the use of hydrocortisone in community-acquired pneumonia, conditionally with moderate evidence. However, these guidelines were released in 2019, and this study was performed last year in 2023. So this study, as well as the conditional recommendation in the guidelines, provide enough evidence to use the hydrocortisone in this patient. So I recommend using hydrocortisone 200 milligrams intravenously once daily for 4 days. And then on the 4th day, the patient should be evaluated to see if they need that additional 3 days of therapy. If the dose, then the dose should be tapered either for 8 days if it was for 4 days, or 14 days if it was for the 7 days. And then the patient should also continue their antibiotic as well as the supportive care. The nursing staff should follow up with the patient every 2 hours. Vitals should be assessed continuously, specifically looking at the O2 sats, and then monitor the patient's weight and glucose daily, white blood cell count daily, a CBC daily, sputum every 2 to 4 hours, electrolytes daily, a C-reactive protein daily, a BMP daily, and then temperature every 2 to 4 hours. That's my recommendation. If you don't have any disagreements, I'd be happy to put in an order. Did you have any questions for me? Okay.